Hello, everyone. This is Zach Ford with AIDS United Sector Transformation Program. Thank you for joining us today for the second webinar in our monetization series. This webinar will focus on reaching out to the payer community. The webinar will last approximately 1 hour and will include time for Q&A at the end. Today's slides and a recording of the webinar will be available on AIDS United's website. As a reminder, this webinar is being recorded and participants are in listen-only mode. You can listen by calling 1-866-740-1260 and using access code 876-2819 or enabling the audio and ReadyTalk to listen over your computer speakers. If you have any questions throughout the webinar or any technical difficulties, please use the chat button function in the bottom left of your screen. At AIDS United, our mission is to end the AIDS epidemic in the United States through strategic grant-making, capacity building, policy, technical assistance, and formative research. We are a national nonprofit organization with a singular mission and focus to end AIDS in the United States. We lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS. We have given more than $104 million in direct funding and leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. And we inform the field with best practices and lessons learned. We advance advocacy based on sound public policy, strategic grant-making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. We work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia and transphobia, socioeconomic inequality, gender discrimination, and stigma. This webinar series will include free one-on-one coaching with the Menzies Group on a first-come, first-served basis. Any HCBO interested in individual coaching by the Menzies Group regarding establishing and strengthening relationships with payer organizations should email myself and Paola Barona at st@aidsunited.org. And with that, I'm going to turn things over to the Menzies Group.
Thank you, Zach. Hello, everyone. My name is Mohammed Hamdan, and I'm a research consultant here at the Menzies Group. And we also have Joel Menzies and Purnima Singh, who will be presenting along with me. So, for session 2, our main goal today is to teach HCBOs how to market their services and capabilities so that you guys can establish more meaningful relationships with payers through a systematic approach. And so the outline we're going to be taking today is proactively reaching out to payers, showing you guys how to provide evidence of your work to show your value, and aligning with payer expectations. And so the first slide over here, tools to identify payers. So Medicaid and Medicare enrollment levels by health plan are public information, and they provide a useful proxy as to which health plans are serving large numbers of people living with HIV. And I've attached a hyperlink to the AIDS United website where we have 3 tools that can serve as good resources to how to track Medicaid and Medicare enrollment. And so Tool C is a spreadsheet that lists enrollment levels for each MCO in 39 states, including the District of Columbia. And most of these MCOs serve many people living with HIV, and they represent potential contracting partners for HCBOs. And generally, the overall Medicaid enrollment across different MCOs will serve as like I said before, will serve as a good proxy for the distribution of Medicaid population living with HIV who are enrolled in these MCOs. Tool D has a similar layout to Medicaid enrollment tool, but includes Medicare Advantage enrollment for March 2017. So 34% of all Medicare beneficiaries are enrolled in MCOs through the Medicare Advantage program. The MCOs with large Medicare enrollment, likely have a sizable number of enrollees living with HIV, and these MCOs should be considered as contracting partners. And then the last tool that we have, Tool E, lists the Blue Cross and Blue Shield companies by state. So if you're seeking to partner with private health insurance payers, you will need to research the key payer entities serving your specific geographic area. So we've included this tool because Blue Cross and Blue Shield often holds a significant market share among employer groups and individuals who have private insurance. And so this tool should come in handy and save you some time and effort as you research this market. And so on this slide over here, we've listed some individuals who would be key to getting you good information as to which payer entities would be best to fulfill your interest in contracting. So staff at the Medicaid agency, as well as legislatures and their staff, have strong familiarity with Medicaid MCOs. So meeting with these state-level staff and participating in meetings on the design of managed care programs can be useful in getting their input as to how to best contact with the MCO. Contacting representatives at the AIDS Drug Assistance Program can help you obtain suggestions regarding MCOs to contact and then individuals within these MCOs. Many HIV ASOs already have connections to the payer community because they directly provide health services to the MCO's enrollees through either a primary care health center, a pharmacy, and other clinical services. And while the contact person for contracting for health services will likely differ from the individual responsible for community partnerships, these existing relationships that you would already have can be used to explore case management and other types of contracting partnerships with these same payers. For donation relationships, in some cases, HCBOs receive donations from one or more area payers, but they haven't yet explored relationships to deliver care coordination programs or other mutually beneficial contracting partnerships. So creating a liaison with donor contacts could also provide an inroad to these types of partnerships. And so for other regional medical providers, in a similar vein, HCBOs and payers are in frequent contact with area hospitals, infectious disease physicians, and other area providers. And so it could be useful for your organization to speak with these clinical providers about the Medicaid MCOs and to obtain their contact information. With these providers and with other ASOs or HCBOs, the initial contact might best be a three-way meeting or a conference call arranged by the middle entity. And then having direct outreach to payers. While we don't recommend this as the first option, if your organization can't really find another door-opening path to contacting a given health plan, a direct call or a letter, which we'll be going over shortly, or even an email is always worth trying. The cost of this outreach is negligible. You guys really don't have anything to lose just by outreaching and trying to get in contact. And so going on to the introductory letter, we put together draft text of a sample intro letter that you could send a potential payer. So the text highlighted in yellow is where you would include the information pertaining to your specific organization. The first half will include high-level information about each CBO, so the number of enrollees you serve, how long you've been around, etc. The second half will include the specific services you would offer to the payer as part of this contract. And so this might include some ongoing case management, directly providing meals or other nutrition support, as well as medication adherence support. And Joel will be going over these later on in the presentation. And Joel also will be going over having these conversations occur at your office. And so we really recommend that you guys track your discussions. This is just a good way to be organized, keeping track of the first point of contact, any follow-ups that you have. And so we've created some information that would be helpful in creating an Excel template, just like I said before, just to keep you organized. So including the payer's name, the person responsible for the initiative relationship at your organization, the payer contact person, and all of their contact information, the date of initial outreach, whether it was a phone call or an email, and then next steps with due dates. So actually giving yourselves deadlines to meet will be helpful in really motivating you and your organization to really continue this contracting effort. And then lastly, giving the progress of the contracting effort. So noting down the key barriers to overcome and any areas of opportunity or concern is always really good to have handy. And then now I'm going to give it to Purnima.
Thanks, Mo. So I just want to go back to something Mo just said. The deadlines and the way that you engage internally with tracking and discussions, I believe that MCOs are also appreciate that. So in your conversations with payers, feel free to be transparent that we'd like to thinking of, of a 2-month window in terms of how long it might take to contract. You guys agree. And move that conversation that way. Be very transparent that you'd like something achieved within 2 or 3 months so you're on the same page. Okay, so as I progress to my slides, I am just going to take 2 minutes if everyone's okay with that. We're having a technical issue that we can quickly fix, and just hold on the line for just a second. All right, there we go. We're back. Thanks, everyone. All right, so I'm on slide 15, and we'll go ahead and move to slide 16. But this section is really about demonstrating and showing your value. This is how you get the hook. This is your company, your organization, and what is that you guys are offering that is different than what the payer is able to achieve. In our last conversation, we talked about how the payer really needs the ability to build that trust with their members and how the ASO has that relationship. And demonstrating the commitments and, demonstrating what you've achieved thus far with the current population you serve and the stories, the actual tangential, the stories that actually, that resulted from the impact that you were able to make. The impact that resulted from the work you guys were able to do is what I'm trying to say. Is very valuable for the payers to hear and understand. Day-to-day isn't on the ground for them, and making it very real is super helpful. So slide 16 is about marketing your services. The first bullet is about providing de-identified case study examples. Of course, everyone understands HIPAA on this phone, so we're not going to talk about that, but really providing substance to what it is that you guys were able to help one member with, and go outside of just their clinical needs, but really, get into the sticky stuff around, their housing, around any other social supports that you were able to close, because payers are more and more responsible for that as well, not just their health needs. And even if they're not responsible for social services, they understand that, in order to tackle that social health service bubble, you need to reduce the barriers and remove the barriers to social services. So demonstrate that, explain that, tell that story. Second area with marketing your service is really measuring the impact, providing solid data on this is where your patient population was at when they came in, and this is where they are today. Utilization of services, viral load suppression data, pharmacy adherence data, cost savings are great metrics to demonstrate to payers the type of metrics that they're looking at, that they're liable to report to the state. Slide 17 provides an example case study, and I think it's important for us to actually read through this and walk through it. There's many elements in here that really helps anyone reading it hit home, right? And so let's carefully go through this. So this was drafted for one of the 4 case studies that we worked with earlier last year, as you'll see in the title. And this case study is about Dexter. So when Dexter first came to Crescent Care, he was homeless, underweight, alcoholic, and depressed. He was referred to the Crescent Care's clinic by the University Hospital. After a recent move to New Orleans from Milwaukee, Wisconsin, and an existing AIDS diagnosis, Dexter did not have the clinical and social supports he needed to care for himself. So this is realize this is his clinical and social needs, and this is where he was in his life. The next paragraph, at Crescent Care, Dexter was set up with a case manager and a physician. The case manager helped Dexter identify and attend peer support groups, engage with a behavioral health therapist, and access medications at the on-site pharmacy. So that's really, very telling of all the services that they can find in this one location, and also speaking to integration. His case manager also helped him find housing, drastically helped him improve his adherence and emotional well-being. Since Dexter's engagement with the Crescent Care, his medication regime has changed from 10 pills twice a day to 1 pill once a day. Again, very hard metrics on this one person, and but the ability to make this type of impact on others is very telling here. Today, Dexter has an undetectable HIV viral load and has a T cell count of over 1,000. Dexter is now at a healthy weight and has celebrated 1 full year of sobriety. So I'm sure that every organization has similar cases, and it's the fact that it needs to be told, the story needs to be conveyed, and what it is that you guys, your organizations independently are offering needs to be conveyed within it. It's not just, here's this person and this is what happened, but what is it that you offered that made that change, made them change their behavior, and made their circumstances different. The next slide, slide 18, provides some examples of performance metrics, HIV viral load suppression, prescription of HIV retroviral therapy, and a few other measures that, again, would be telling in a case study. If you guys have pre and post for these measures, that's also great. If you have other ways to provide a sense of where you guys are with your patient population on these data metrics, that's very helpful for an MCO or a payer to really assess and get them excited to want to contract with you, because, again, they are contractually liable to the state for most of these types of measures. And understanding which measures contractors are liable for is pretty easy in the contracts that at least the Medicaid payers have with states. With the state Medicaid agency, it's usually clearly outlined what measures they have to report out and are also liable for arrangements or performance arrangements with the state. All right, so now we're going to go ahead and move on to Joel's slide.
Hi, guys. Hopefully you can hear me okay. I'm in a different location in Purnima. So just circling back to some of Purnima's content and following up on the one-on-one sort of things, we've just barely gotten started with one entity, and we're close to getting started with another entity on the one-on-one. But one thing in an email we sent out today to one of the clients that's pertinent to the broader group of you is surveying your members if possible to just identify how much hospitalization they had in the year before they started coming to your site, and how many hospitalizations they've had per year since they've been working with you and you've had the opportunity to support them. How many months of homelessness did they have before you were working with them? How many months of homelessness after emergency room visits? How many average days of drug use per week? How many drinks involving alcohol per day? Things like that. If you can get a handle on what you've meant to your members, to create statistical proof of what you're doing, in addition to the Dexter type stories that was on Purnima's slide a couple slides ago, can really be helpful in teeing up the value you're delivering to the population in a payer's eyes. Another just introductory thing to say about the payer community is, I think oftentimes there's a wariness, and I may have said this on the last session. I don't know how many of you were on last month's, but it's real helpful not to view payers as evil empires. I think nationally, certainly we do most of the work we do in the Medicaid managed care arena. We work with a lot of them all the time, but they're far from that fundamentally in their organization and in what they're trying to do, and their profit margins nationally are right around 2 percentage points. So it's not an industry that's gouging everybody, and when they do everything they do to steer things towards lower cost drugs and avoid hospitalizations and so forth, they're barely eking out an existence at the end of all that. They're not running off to obscene largesse with the money they're making doing what they do. So I think it's important to view them, and this is not to defend them against anything they may do horribly wrong with any given patient or in any given provider relationship at all. There's that side to human behavior in every industry, but the Medicaid managed care industry that my career has been in is an exciting, admirable industry in the overall, and approaching them from the point of view of how you can just help them achieve their objectives, which are often aligned, not opposed to what you're trying to do, is a conversation we're hoping to help create in the introduction. Going back to the slide content finally, sorry. The types of services that you might provide or in any given contract are going to be a sample of one. It depends on what you do and what any specific payer wants and needs, and you meet in the middle there. But I think the defining value that you guys have is your closeness to persons living with HIV, your understanding of all of their dynamics, your tailoring of what you do, the intimacy with which you know what's going on in their lives in and around, not just with their clinical conditions, but all the circumstances that may have both led to infection and both challenge and compromise their ability to cope with both their health care and all the social determinants. But a common thing that an entity like your guys' may do with a payer is to connect with people in their home and get a full intake of what's going on in the home environment, accompany them to office visits. Accessing care is a monumental barrier for a lot of particularly low-income populations, with and without HIV. But literally holding hands into a clinical site can be very valuable. But phone and email and texting outreach to just support the member. If there's a drug abuse issue, staying connected and supportive and so forth. That's sometimes it takes a village, but you guys are in a much better position to be that village, or to be forefront line supportive people to persons with HIV than they are when they've got a broad base of 200,000 members. Medication adherence support is obviously clinically what's turning HIV from a death sentence to a chronic condition, and I'm looking forward to some more patent expirations where medication adherence becomes also a low-cost thing for the health plan. At this point, the cost of the drugs is at times almost obscenely high, and that's a challenge everyone faces. But it makes the health plans financially more wary of someone who isn't yet symptomatic of getting them as strong of adherence, because that may not pass a cost-benefit test in their view. But $20,000 plus per year cost regimen is something that first and foremost just needs to come down, and that will with the patent expirations. But secondly, the cost of hospitalization is much more than that. The cost of crashing into the hospital again and again is much higher than that. So medication adherence support is a key way over time that you guys will be enormously valuable to the payer community. Psychosocial assessments, and it's kind of circling back to the first bullet, really getting your hands around everything that's going on with the person and their living circumstances and their caregiver or caregivers' abilities to play their role are very central to things that you and arguably only you can do well for this population. So those are just different points of entry to help the health plans be successful with your members. As Mo alluded to earlier, we're encouraging, this is the next slide, that if possible, the initial meetings, or at least one of the initial meetings, occur at your site rather than their offices. Our webinar series was emanated from a project we did with AIDS United last year, working with 4 entities, and they were all pretty convinced that 4 specific sort of case study entities, and those are in the reports that are available online that Mo referenced. To look through those can hopefully be helpful to you guys, beyond this webinars. But one thing they certainly felt is that when people come in and look at what they do, they are more attracted to it than when you're just talking to them about it and they're not seeing what you do. And so if the meetings can occur at your offices, and if your frontline people can vividly give them examples of what they're doing for their clientele, I think that can make a stronger and more accurate impression than just selling it verbally can. So we encourage that you try for that the other parties will make their own decisions. And another, just puppeting Mo from earlier, if you can triangulate something with your providers who they have a relationship with the frontline HIV care providers, who also come at the same time, you kind of create an aligned team model that you become part of, quite possibly. But we think all of that occurring at your office is ideal. And the title of this next slide is Overcoming Initial Payer Awareness. I mean, that's meant to be wariness on the part of the payer towards you. They do often get bombarded with entities who have an angle. If you pay $10 on me, I'm going to save you $50. They hear that song all year long from all kinds of entities, and quite often it's a false, it's fake news, and they've got to see through that. But they do, somewhat understandably, have a wariness about the next person in line who comes to them with that story, and I think one way to overcome that at the outset is to not try to catch a $6 million contract or a $1 million contract from the get-go, but to prove your way in by doing work on a small pilot scale, demonstrate your value on with some of the patients that with data analysis, and we'll get into this in the upcoming series of the webinar in much more detail, but looking for the subgroup of the population that are most fruitful to both your parties, where there's an almost certain win-win to occur because they've had so many hospitalizations and they are going back to their crummy circumstances after the hospital fixes them up and they're back in the same, the tape just keeps playing, and that's where you guys can really make a clinical and financial difference if you're allowed to plug in. Identifying the potential advantages of the partnership in terms of the social determinants and the most challenging enrollees is, I think, the very best way to start this, as opposed to trying to, cast a real wide net where it's going to be a harder sell in the first place, and it's going to be harder for you to give them a financial win in the first year. And that's critical to having a second and third year relationship and so forth. Another key thing going on in the payers world is they need to win contracts. Like I said, in the Medicaid arena, where a growing number of the HIV population is covered, particularly in the Medicaid expansion states, which are now something like 33 of the states, they need to win a bid to exist, and the states procure their Medicaid MCO contracts about every 5 years. Those are the biggest contracts that the state has across anything, across transportation, education, et cetera. There's a fierce competition for those contracts, and having a relationship with local little guys like yourselves can be a real attractive selling point for the health plan. So one thing to be mindful of is when the next procurement is coming around in your state, and try to align with some of the health plans a year or 18 months out before that procurement to help them strengthen their hand as they kind of go to war to try to win a contract. That's a path in that the procurement creates that you might not otherwise have. The cost of hospitalizations and ED visits and so forth are just so high that there are for sure win-win people out there for you, and we'll get into this more, but the maintaining folks who are going to crash and burn, if you will, again and again, maintaining their stability such that they aren't hospitalized is just a phenomenal victory for those people clinically, for the people, for all their significant others, for you guys if you're the ones helping make that happen, and for the health plan. They do care about people's clinical betterment as well, and it certainly helps their bottom line. So there's just all arrows point in the same direction with those people, that it makes sense for you and the health plans and the providers, the frontline HIV providers, to get on one team and help these guys. And I think there's a very good contract opportunity for a lot of you in that direction. With that, I guess I'll just mention, we'll take questions, but I'll just mention a couple slides down. We've just listed out what the next webinar dates and topics are, things that I've mentioned already, creating the pilot and some of the aspects of the effective contracting we'll spend the whole hour on in the next two sessions. And so with that, I'll turn it back over to you guys to just organize the Q&A process.
Thank you so much, Joel and Mo and Purnima, for that presentation. We are now going to open it up to a Q&A session. So if folks have anything they'd like to ask about today's presentation, then you can use the chat box at the bottom left of your screen to type up your questions and send them our way. And we'll just hang tight for a couple minutes while we wait for some questions to come in. All right, so we've got one question so far. Someone wants to know, can you please comment on the health home model for HIV care?
The fundamental pieces. So there's a lot of providers who are becoming qualified health homes in various arenas, but the fundamental path to getting sort of comprehensive care in place for any high need person, persons with HIV certainly fall into this umbrella, but there needs to be a comprehensive assessment of what's going on. Let's just call the infected person Stu for this walkthrough. But if you can get connected with Stu, literally face to face is ideal, and see what's going on in the home, what the housing circumstances are, discern how long Stu has lived in that residence, how many different places he has lived in the past couple of years, who lives there with him, what the safety is, what the risk of homelessness is, and what the pattern of homelessness, if any, has been for him, or hopefully stable housing. But getting that dimension covered in the assessment process, diet, nutrition, weight issues in either direction, could be problematic. Getting a visual face-to-face can help a lot with that, by the way. And then going through other aspects of social determinants in terms of just the person's incarceration history, if any, the family support and social support network that the person has, spiritual, etc. But getting your hands around all the non-medical things, as well as, of course, a full clinical assessment of what conditions, in addition to HIV, and unfortunately there usually are additional ones, is the person beset with, and how long has Stu had these things, and what meds is he taking, and how adherent is he, and so forth. Getting a full assessment package together, and then once you have accomplished that, having a specific care coordinator who puts a team together, depending on what Stu's clinical and non-clinical needs are and strengths, but trying to create an individualized care team, which would include a primary care provider, and probably an infectious disease provider, but oftentimes substance abuse provider or behavioral health provider. For persons in this population, there's tremendous comorbidity with behavioral and substance abuse challenges. If it's diabetes or cancer or whatever else, but getting an appropriate team together that can contribute to Stu's betterment across the totality of what's going on in his life, and developing what we call a care plan or a treatment plan. And here's what we're going to do to try to make Stu as well off as possible and stable as possible over the upcoming year, and everybody has their role in that, and everybody signs off on that. And then implement that treatment plan and circle back, and as circumstances arise, whether it's a lapse into homelessness and you've lost contact, or an incarceration, or recidivism of substance abuse, or whatever it is, a hospitalization, modify the care plan and modify the care team if need be, and then just continue to deliver the best plan of care, the best evolving plan of care that you can along the way, but stay connected so that you can evolve your treatment plan and see how it's working and modify it appropriately. That's the package of things that strong sort of state-of-the-art care coordination entails for people. And by the way, non-clinical people like a daughter or son or a parent or a best friend can be on that central care team as well. People that are significant others in spouse, obviously, in the person's life are often, critical to have in the central team that's trying to create the best probability of sort of a circle of support or whatever to get the person the best chances as possible to do well. But there are specific. The question may have focused more on the specific provider types who are working towards becoming health homes and delivering this kind of package of services I articulated. And there's certification process for that. NCQA has that for patient-centered medical homes. There's a lot of literature you can point to, and if you want to email us, we can get that to you as well. So I'm going to stop a kind of monologue on that.
All right, thank you so much, Joel, and thank you to one of our participants for such a great question. Please send in some more questions. We've got about 18 minutes set aside for the rest of the webinar. So to the folks that are participating today, we would love for you to share some more of your questions that we can pose to the folks over at Minges. In the meantime, while we're waiting for those questions to come in, I would like to go ahead and look at the upcoming webinars in the series. I know Joel mentioned these briefly, but just as a reminder, and so folks can maybe copy these down if you're looking at the slide, we've got a webinar on September 20th on establishing effective contracts with payers, and on October 11th about creating the pilot program. And then on November 15th, we'll be discussing collaborative learning. And lastly, on December 6th, next steps. Once again, we are accepting questions, so please send those in, whether they're related to today's information on reaching out to payers or something else that might be covered under the monetization series. We are accepting questions covering the entire topic. I also want to remind folks that if you feel that your questions are too specific to your organization or that it's just too much information for you to put into one single question, that we are offering individual coaching. So any HCBO or any CBO that's interested in coaching with the Minges group, that is available on a first-come, first-served basis. There are still slots that can be filled, so we encourage you to reach out, and you can do so by emailing myself and Paola at the Age United Sector Transformation email address, which is st@ageunited.org. There will be a brief eligibility screening, and then I will put you into contact with Mo over at the Minges group to set up introductory meetings. So it's a great opportunity for any organization that's considering revenue diversification or contracting with the payer community. And once again, it is free, so we encourage everyone to sign up for that. So at this time, I am not seeing any new questions. We have about 16 minutes still set aside. So if you have a question, please get that in the next minute. And if we don't hear from anyone, we'll wrap up. And I just want to say, while we're waiting during this minute, that if you have any specific questions that you want to send directly to the Minges group, you can email Mo. His email address is mhamdan, HAMDAN, @themingesgroup.com. All right, so according to my clock, our minute is up. So I think we're going to go ahead and wrap up today's webinar a few minutes early. Once again, the recording and the slides will be made available on Age United's website. And we look forward to seeing folks on September 20th to attend the webinar focused on establishing effective contracts. And if you would like to sign up for the coaching, please reach out to myself and Paola at st@ageunited.org. Thank you so much for participating in today's webinar. This concludes the presentation.
Thank you, everyone, for joining. We really appreciate it. And as Zach said, if you guys have any questions following the webinar that you just didn't get that you just thought of or just didn't feel like mentioning to the entire group, feel free to email us directly, and we would love to get in contact with you guys and answer. Thank you.